Hey, good morning. This is Steve Stites, Chief Medical Officer here at the University of Kansas Health System. Delighted to be back with you on this beautiful Tuesday morning in March with spring coming and a lot of rain coming at the end of the week. That'll start making it feel really like spring. I'm delighted to be joined this morning by David Wild, our VP of Performance Improvement. David and I have worked so closely together. He's really our right-hand man here for the system around the pandemic and has done a great job. Also, of course, Doc Hawk here on the right. And Doc Hawk has been our leader for all things medical director of infection control, and Dr. Lee Norman, secretary of KDHE. Welcome back, Dr. Norman. Always good to have you here. All right,
Dr. Stites.
All right, awesome. We've got one heck of a crowd this morning. We're going to start, though, with reporter questions. Let's see what's out there, because I'm going to bet there's going to be some CDC questions today.
Good morning, Cody Holyoke with Channel 9.
I'm so glad you're on, Cody. I knew you wouldn't let me down.
No. Yeah, I'm here for you. This is a couple questions for Dr. Norman. I was curious, now that Missouri's going into its kind of tier 3 on Monday, what the timeline is now. Is that changed at all for phase 3 in Kansas? That's my first question.
We've numbered things a little bit different than Missouri and a little different than the CDC. We are in phase 2, which is by far the largest phase in Kansas. It's about 1 million people. And some of the counties are actually through with phase 2. Those are some of the smaller counties. And they therefore are on pause, as we call it, for receiving additional vaccine allocations so that we can reallocate it to the other counties that are still in phase 2 and moving in an orderly manner through phase 2. We think as a state, it's a good idea to not have some counties move to phase 3, 4, 5, while there's other counties still in phase 2. And when you think about it, where do these phases come from? They came from highest risk people are in the lowest phases. So phase 1 and 2 are obviously the highest risk individuals. So yeah, we've also done things different than Missouri in terms of we've already are done with our teachers and school staff for the most part. There's a few second doses that need to go into people yet this month. We've moved and are going through all the packing plants. We've got about 60 meat packing plants and related industries, and those people that work in those plants, not only are they critical infrastructure, but they're at much higher risk and have had a big illness and death toll. So we've moved those critical infrastructure people up. So it's a little bit of apples and oranges, but we're still marching through phase 2 and hope to get phase 3. I don't know. I don't know exactly. Maybe 4 weeks from now. It could be a little bit less.
Cody, did you have another question?
Yeah, this comes from my executive producer, who's seeing more like local pharmacy, grocery store pharmacies opening up vaccinations. Is that where people should be looking for vaccines? Should they be going to their health departments? Should they be just casting a wide net? What are your recommendations?
What do you think, Dr. Norman?
Yeah, I would cast a wide net, and the reason is because some vaccinating sites are more efficient at getting vaccine into arms quickly and not having much inventory, and some have it around a little bit longer. The best place I think to go is to Find My Vaccine site on our kansasvaccine.gov website. And the reason is you can put in your zip code and find out who, and then you just find the number of miles you want to drive. You can put in your zip code and it'll tell you who has vaccine and who are the vaccinating sites in your area. And then just call them up, or there you go. Call them up or go to their website, for example, of a health department. And yeah, the retail pharmacies are getting a lot more. That doesn't come from us. The retail pharmacy program comes directly from the federal government to the retail pharmacies. And there's a lot of, there's big guys, CVS, Walgreens, et cetera, but there's also a lot of the independent pharmacies that are part of an independent pharmacy network, Dillon's, Kroger's, and those kind of things as well. And the pharmacies are expanding their population. Initially, it actually relates to your earlier question. Initially, they were just vaccinating people over the age of 65, but we've expanded that because we pretty much finished that population that wants it. Now we're doing, the pharmacies are doing childcare workers, grocery and retail people who are, at, as you know, very high risk and are critical infrastructure, food service and food manufacturing, factory workers, long-term care and assisted living. So they are broadening and have vaccine available. None of us have as much vaccine as we would like to have, of course, But check the Find My Vaccine site on our website.
All right, other reporter questions.
I have to ask because they make me write it down every day. Hawk, do you have the latest numbers?
I do.
Oh, yeah, I did skip over those. I can tell us out of practice. I wasn't here on Monday.
That's all right. We would have come back to it eventually. Numbers are still pretty good though. Luckily, still low. We know that the numbers in the Kansas City area for new cases is lower as well. It's continued to decrease. So 11 acute patients in the hospital right now. 2 in the ICU, but those 2 are on the ventilator. But 23 in the recovery, so total of 34 patients, which is really good. Hayes is doing well, also with 2 active and 8 in the recovery phase. So we just keep getting, bigger smiles on our face as those numbers continue to decrease.
David, you're like the guy of all statistics here. So how long has it been since we were at 11?
Well, we talked a little bit about
Yeah.
this yesterday. The overall number, like 35, is July, August. And if you think about July and August, we were actually worried that was going to be a challenge.
I know, I
now it
remember
got
that.
much worse. But
Now it's like vacation time.
actual acute numbers close to 10. It's been some time. It's probably been since early summer. That's probably a June
I
number.
was thinking the same thing. That's a long time ago. Don't get cocky, people. All right. Other questions? Jess, you said you had a
Hi, doctors. Good morning. It's Taylor at 41.
Hey, Taylor.
Taylor.
So I don't have to tell any of you that response to CDC guidelines over the past year has been mixed at best. Sometimes whenever people feel like they are saying one thing, then changing it at a later date. My question is, can this, for lack of a better phrase, cat be put back in the bag after the announcement yesterday? If we get some sort of huge numbers from this, and there's numbers that come back that say people are taking this too far, now that they're saying they can meet with families, they're meeting in small groups under certain circumstances with vaccinations in place. What if the CDC has to come back in 4 to 6 weeks and say, okay, we got to go back. This was a bad idea. People are doing this wrong. Can this be undone if it has to be?
Oh, I think we've had to undo it a few times already,
Yeah.
so I think we can undo it again,
Yeah.
Lee. I mean, that's been part of the whole task has been trying to figure out what we were doing while we flew the airplane.
Yeah, there have been some fits and starts, and I think that one of the things, and I've said this for 412 days. I first said it 412 days ago when we stood up Incident Command. Not that I remember, but and that is there's principles, and that is keep yourself safe. And Steve Stites and others have been harping on this for every day. I shouldn't say harping, have been reaffirming the importance of it every day.
Good verb, too.
And yeah, so principles are what really is at play. And yes, then there's rules. I think the CDC, to your point, Taylor, that if we have a plateauing and then worsening, it's awfully hard to make people step back and become more restrictive. So we're taking a very measured approach. We typically align ourselves with the CDC because they don't base it just on ideas pulled from the air. They base it on the best research and evidence that's out there. I think that we're going to meet with the Department of Commerce today, and I think the governor and I will probably have something to say about this tomorrow afternoon at the press conference, because we want to make sure that we don't over liberalize, if you will. There's still a state executive order out there, mask that 80 plus counties are following, and we want to make sure that we aren't too restrictive and or too liberal. I can guarantee you we won't look like Texas.
Yeah, please do not do that. Please do not end the mask mandate.
But I think just like Dr. Norman said, a lot of it's going to be based on the data. What's going to be changing in 2 or 3 weeks? What are those infection dynamics like, both nationally and locally? Because we know that, the local health departments and governments can make different changes as those infection dynamics and numbers change, hospital capacity, things of that nature.
Yeah, you and I have been made it kind of our little amateurish observation time to go down and walk on the plaza or around Lewis Park, and you can see what's going on. And I actually think it's pretty reflective of what's going on.
Yeah.
It is so much better today than it was, 6 months ago. People really do wear their masks on the plaza. They wear them outside. Lewis Park, there are people gathering, but they generally tend to be a little bit further apart, even on a warm day. It is just better. My fear is things get warmed up, people start taking their masks off if they haven't been vaccinated, and then all of a sudden we're going to see a rise. I don't think we'll see the same surge because there will have been people that have been vaccinated.
Right.
But if you're the guy who hasn't been vaccinated or the person who hasn't been vaccinated and you get the infection and get really ill, it's still going to be bad. I think we just have to be really careful. I think it's not time yet to take off all the masks and try to say we're normal. We are not normal.
And it is definitely hard to be doing the masking when you're actively exercising or trying to be active in that way. But a lot of people on the plaza who are just around shopping, they're still wearing their masks out all the time in the streets and doing that. I think that's reasonable. You know, it gets a little bit more difficult if you're doing exertion and playing or walking or running, things like that. But certainly the masking overall has been a lot better.
And I would maybe add a couple of things. Remember yesterday, our Children's Mercy team explained that it is likely going to be 2022 or maybe even 2023 before we vaccinate children, before we get through all of our children.
No, we're going to say it's normal by 2022.
And so when you sort of talk about this, right, when can you, after a vaccination, when can you start doing things different? Well, there's going to be a lot of families who are unvaccinated as a family for a long time still.
Yeah. So Lee, please don't be Texas. And we could even say, the eyes of Texas are upon you. Don't take off your mask. How's that? What do you think, Norman?
That was wonderful.
Do I have another career?
Well, that's why I want earplugs and not a mask.
Hey, it's Taylor. As a Texan, I take offense to that. I'm just going to throw that out there.
Well,
No,
we're
it's not
being
okay.
kind. We're being kind. We're just saying, don't take off your mask, Texas,
I
please.
think it was your singing he was offended.
Oh, my singing was
Oh, it's
offended.
great.
Okay,
It was
Taylor, that's
wonderful.
fair. My singing offends easily. Sorry. Did you have another follow-up question, Taylor?
No, that's all for me. Thank you.
Okay.
Okay, Kaylee from the Shawnee Mission Post has a question for Dr. Norman. I know Kansas is trying to keep counties all together on the same phase, but some counties like Riley County might not be abiding by the state's guidelines for vaccine rollout. Has KDHE heard anything about this? How does KDHE deal with counties that diverge from Kansas's phased vaccine guidance plan?
Yeah, that's a great question. And it kind of relates to the earlier one about phases, and that is we're trying to move everybody through at the kind of the same general pace. When we statewide get to the end of phase 2 or nearly so, then most certainly we're not going to be nitpickers about it and will allow counties to move into phase 3. But when we're nowhere near that, and there was an issue with the county, we talked with them and they changed. We did not withhold vaccine to them. And one of the reasons for that is that it doesn't make sense for the populace of those respective counties to not receive vaccine in a timely manner. So we negotiated with them, and they have fixed the protocol, if you will, for the vaccinating prioritization schedule, and you can negotiate your way through almost anything, and we fixed that easily with them.
Okay, Ryan from K-Witch in Wichita has a question also for Dr. Norman. Recently, commissioners sent a letter to KDHE where they asked to move those with underlying health conditions up into phase 2 of the vaccination plan. Currently, they are in phase 3. Can you explain the reasoning as to why this group is not higher up on the priority list?
Yeah, that is a really good question. And yeah, I did see the letter from the commissioners, and the health officer there, Dr. Gerald Mins, who I've worked with very closely throughout this, had given me warning. And no surprise. I mean, the question, of course, is where did the phases come from? Dr. Kevin Auld talked about this last week or two when he was on, about not only vaccine approval, but the evidence behind where to place people based on their risk. And the one question I think is a real interesting one. Okay, if you move a group up into a higher phase, who do you move out? And on what philosophical or scientific or epidemiologic grounds do you move somebody to a lower phase? Because it wasn't randomly selected that they are in phase 2. A very fundamental question, and we haven't talked about this very much, but I think it's really of importance, and that is, how much do we vaccinate for a population to prevent spread? And I think it'd be fascinating to get Dr. Hawkinson's read on this. So on one hand, you want to protect a population against spread. So you look at retail workers who are very much frontline, meat packers and the like. That is a high-risk population, but they're also at high risk for spread versus an individual. And everybody wants an individual. I would vaccinate everybody if we could, particularly those people that are under the age of 60, because we've already gotten the 65 and olders who are the highest risks. 85% of the deaths in the state of Kansas from COVID-19 have been in people 65 and older. So 15% are below the age of 65. So it's an issue of collectivism. How much do you treat a population and prevent spread within a population versus protecting one individual, instead hoping that they can stay out of harm's way? And there's no absolute easy way to solve that. We just need more vaccine. But it's a good question, and it's also a question from a policy perspective. Who do you want to make unhappy? And that's tough.
I think you could actually go and say, well, should it be obesity? Should it be diabetes? Should it be cancer? Should it be underlying bad lung disease or heart disease? I mean, there are so many special category groups, and then there's combinations of all the above, right? What if you're both obese and diabetic and have heart disease? I mean, we could spend all day trying to rank, or all year trying to rank these folks. I think at the end of the day, Hawkeye, what we try to do is get as much vaccine out to as many people as possible. I think age was a great initial criteria, because one of the problems about being 65 and older, of course, I'm not quite there. Norman's passed. But I think that the real challenge is that by the time you're 65, we all have health problems by and large. And I mean, I have prostate cancer. So does that put me in a different category? I don't think so, not yet. But nevertheless, as you look at the data, it makes you think, gosh, maybe we should just go ahead and try to prioritize it. It just gets really hard to do that.
Yeah, there is that dichotomy there. I agree with both of you between individual and the collective and stopping spread. But we know that individuals, there are certain that are very high risk. And we would all love for everybody to be able to go out and get their vaccination today. And hopefully with more supply coming from Pfizer and Moderna, more supply from Johnson & Johnson, hopefully if one or two other vaccines get emergency use authorized, we'll have that supply within the couple months or a few weeks or whatever that may be, to be able where people can just walk into their local pharmacy or their primary care doctor and get that vaccine. So, but until that time comes, I mean, I think that's the best way to describe how we pick this, i.e. the age group versus these other special individual groups, which they need it too, obviously, but we have to keep all of that in a collective sense, and this is the best and easiest way moving forward.
And the CDC's advisory committee on immunization practices, the group that sort of looked at the evidence and said, how do we best ethically approach this population versus individual question, right? Looked at the available evidence. It actually said, yes, coexisting disease has some impact on your risk of severe disease and your risk of death, but nowhere near the impact of age. And that was the reason for the decision. And so, yes, some states have taken that and moved at different paces, and that definitely has made for challenges. I mean, with our own patient population, for example. But the decision to say age is the primary driver was really based on who's most likely to have severe disease, and as Dr. Norman already mentioned, who's most likely to die. And we started with those groups for those reasons. It doesn't mean it was a perfect answer. I think we all admit if we could address both the population and individual at the same time, we would.
So I wonder if we can move into some cool slides, David. I think you've got some perspective on what's been going on the last year. You had some slides teed up this morning to help us kind of start that conversation about, gosh, it's been a year.
It's been a year. So we talked a little bit yesterday, some great questions actually yesterday about what does it feel like for those of us here, collectively or individually, to have sort of been tackling this for a year. But what we didn't spend a lot of time on is what are the numbers that sort of tell that story. And so that's just a few slides here. And to start with a reference point. 4%. The United States makes up 4% of the world population. But 20% of the COVID deaths documented across the globe have happened in the United States. Now, part of that is related to reporting and testing, no doubt. But there is also, I think, a disproportionate share of mortality, of death in the United States. Also, interestingly, as a reference point, 30% of the vaccine doses that have been administered to date globally have been administered in the United States. So just a lot of sort of grounding points for reference when we talk about how things are going here, whether we're talking about the spread of disease or the vaccination process. So to talk a little bit about numbers in general, right? These are the big picture numbers for the United States. You can see the sort of picture at the top just says, how has disease spread? But the numbers at the bottom are actually probably the big things, especially the total reported. 29.1 million unique cases in the United States. 29 million. out of a population of roughly 330,000.
330 million.
330 million. We also know in that conversation that while we have great high quality testing, we don't test nearly as much as many other countries across the globe. So that number is not high because we have the best testing per 1,000 population. In fact, is probably underreporting by a significant number. And that 29 million and change cases led to 525,000 deaths, more than 500,000 deaths in the United States in the last year. And many of those are people who wouldn't have died if it weren't for COVID.
Exactly.
There's some other numbers on there that talk about what happened on March 8th and what the change is. And those are, I think, important to recognize. But I think the big picture here was, what has the last year meant? And 29 million or 525,000 are sort of staggering numbers, especially for a single disease. So much more than any other disease in that same time frame. The next slide talks a little bit about Kansas. And I didn't share Missouri because there have been a few things that have changed, including yesterday when Missouri started using or reporting antigen tests as positive for the first time in their numbers. So a lot of variability in how things are reported, just another sort of understanding that there's been a lot of different ways that states or counties have reported. There's been a challenge to reconcile. I think Cody mentioned this yesterday, or someone did, that the county numbers in Missouri, when you add them all up, don't equal the state reported numbers. And why is there this gap? And so anyway, it doesn't mean there's anything wrong there. It just simply means it's a little bit hard to make sense of. So here are the Kansas numbers: 296,000 cases, 9,411 hospitalizations, and 4,816 people have died over the course of the last year in one state.
Tough number.
Tough numbers. And finally, some information or numbers about our hospital here in Kansas City. So 2,252 unique patients have been admitted to the hospital for COVID care alone. Some have been admitted twice, so 458 admissions over the course of the year. 331 deaths in the hospital. 644 patients hit the ICU out of that time. 400 of them needed to be on the ventilator. They were about 58 years old, and the average person over the whole course of the pandemic stayed in the hospital 8 days. But there are also some numbers that talk about how hard our teams have worked to support our community, which I think are important as well. They're not just the negative numbers around cases and deaths and hospitalizations. 182,000 and change tests run just here alone in our lab. 12,000 of those were positive. And 35,000, actually a little bit more than that now, probably another 500. So over 35,000 vaccine doses administered here just in the past, December 18th when we got our first dose through now.
That number feels good. I wish it was even higher.
Yeah. And a lot of things, are buried in there. But just a good, I think, step back to say, wow, if you think about any one of those numbers individually, they're staggering. Some in a good way, 35,000 doses of a vaccine in not a large amount of time. And some are staggering the other way, right? 2,500 hospitalizations that maybe prevented others from seeking care here at some point in that time.
It did, right? We know it did. And the fascinating thing has still been the lack of influenza admissions, RSV admissions, and those other things.
Yes.
So we come back to the same point, infection control works.
Yeah, and if I could interject with those numbers about testing, I was just looking at the CDC, and certainly Dr. Norman can correct me, but I looked about 140 million or so influenza tests by state labs or public health labs, only 1,700 positive results for influenza around the nation as of the latest updated CDC numbers. So just to your point, just extreme decreases in influenza and RSV throughout this year, which is amazing.
1,700 positive influenza cases across the country.
And I've said this before, but I would even bet some of those are probably false positive tests if they're done with antigen tests, because we know that if you don't reach a certain threshold of positivity of influenza in your area, you have a higher chance of having actually a false positive influenza antigen test than not. So some of those could be even false positive.
I think that's one of the most remarkable things
Staggering.
about the pandemic, and it is staggering. Lee, you look like, did you have a thought about that, about the lack of influenza and RSV?
Well, to your point, Steve, the masks and distancing and hand washing and those kind of things work well. And we have lots of opportunities to diagnose influenza because, and as you guys know, It wasn't long, number of weeks ago, we went to a multiplex test that includes influenza A and B. So every time somebody orders a COVID-19, we also get influenza A and B PCR test. And that's and there haven't been many positives. So to Dr. Hawkinson's point, there's just not as much transmission going on out there, just not as much burden of the disease this year because of what we've talked about.
So, Dr. Norman, some people have talked a little bit about this being in the eye of the hurricane, this little bit of calm, but do you see another plateau coming potentially? Or another spike, I should say, not a plateau.
Yeah, I'm sure we will plateau off at some level. That it's, of course, difficult to know, will we continue to drop? And because the virus doesn't act on its own, it acts also on what we do to it in terms of masking and isolation and those kind of things. So I think that we're going to continue to show improvement. I didn't hit the numbers today, but on Monday, yesterday, I guess it was, we had only 4 additional deaths, and every death's a tragedy and saddening. But to have only 4 deaths in 2-day period, and there was one period last week where we had 0 deaths recorded over a 2 or 3 day period. So I mean, it's really improving the number of new cases statewide. Dana talked about the number of cases at KU. We're seeing that too. Remember we were in the thousands per day, 1,000 to 2,000 new cases a day. Now we're seeing it at maybe 150 cases a day by comparison. So everything's on the up and up. And a very striking number is 2.9% positivity rate since in March. Now, granted, we're not that deep into March, but remember when we were at 18% as a state, and now 2.9%. And to the question about antigen testing, yeah, we're going to lose control of counting antigen tests, and especially with home tests and all tests that people do at home that are rather like home pregnancy tests. We won't ever know a lot of those numbers, but we've done about 2.5 million PCRs and another 500,000 to 600,000 antigen tests that have been recorded. So we're trying to keep a pretty good eye on that, and we've actually started a push during spring break called Know Before You Go. We still have free testing throughout the state. You can go to our testing website. Because we think that we might see a little bit of a bump at an increase, that is, at spring break time with people doing a lot more traveling than they have been. And we're encouraging people to test before they go and test upon return, just to identify cases that may not be symptomatic.
I think warm weather and spring break and that kind of travel are going to be a real test for us about how good we really are.
Yeah, and it's interesting, there's been a lot of talk today about CDC guidelines saying that even if you've been vaccinated, the recommendation is still don't travel. And the reason for that was every time we have seen our population in the United States travel, we've seen a surge. Follows. And so, although it's really hard to reconcile, you can gather privately in your home with people if you've been vaccinated, but you can't travel. Well, their reasoning was our evidence says, until we've proven otherwise, every time we have a spring break or a Thanksgiving or a Halloween or a Christmas, we see cases increase. And so, and let's not do that right before spring break, which I think is understandable. It's the best evidence that we have, but it is a little bit hard to reconcile with some of the other guidance.
It is. It's a little bit hard, but what they're really saying is we don't know enough. We're still building the airplane, and I think that's the problem.
Yeah.
We're still building the airplane. We just don't quite know enough. In fact, it's one of the interesting things I find is that when they say everybody's going to get offered a dose of vaccine, changes constantly. At one point, it was going to be the middle of April or March, and then it was going to be June or July, and now it's back to May. So, Lee Norman, let's assume that that's right, that it's going to be by the end of May, everyone will have been offered a vaccine. We're all going to be really busy offering vaccine here in the next 2 months if that statement's going to be true. What are you doing to get ready for that?
Yeah, there's a lot of acceleration of the pace. I mentioned last week we got 23,400 of the Johnson & Johnson vaccine doses. Then there'll be a long pause in that on ostensibly on March 23rd. We're going to get a very large increase in that. We don't have half of our vaccinating sites up and running. We have over 1,400 that have registered, and a lot of those are medical groups, pharmacies, especially medical groups and pharmacies, really. So we'll just have to expand the vaccinating base. We haven't had the vaccine to merit doing that yet, but we will. So it'll be farther and wider with more vaccine. And I say bring it on. We've done a sensitivity analysis. We figured that we could increase from what was our baseline amount of vaccine, we could increase it 10 times with the existing vaccinating capacity we've had. We have a lot of really terrific vaccinating sites that are doing 5,000 over a 2-day period, for example.
We could do that. So are hospitals going to get to play a role?
I would expect so. Yeah, the health departments have been kind of the centerpiece in terms of the distribution and then working with their community to serve the 105 counties the best. And hospitals are good at it. I'll be on a call today with the medium and smaller hospitals to take their pulse and see how they're positioned. But hospitals have done great. We do have inventory around the state that could be redistributed some. I've talked before about the diagnostic that we've been doing to figure out why we have a data gap between the number of doses administered and the number of doses that have been sent to the state of Kansas. And we have found out that about a third of the gap is due to data glitches and HL7 interfaces between medical records and our WebIZ. But about the other 2/3 is inventory is on people's shelves of first doses. Second doses will always be some static inventory waiting from 1 week to the next to give to people their second dose. So we've really, even in the last week, have a lot of great information to act upon to find out where we can solve this data gap issue.
This up on a shelf is not helping us prevent the spread of COVID-19.
No, and we've been rather directive about not having inventory sitting on shelves.
So as you look back over the last year, if you could have said, I would do this differently, what would you do differently? Now that you know what you know, what would you have done differently?
Yeah, we stood up Incident Command 413 days ago. We saw this coming in December of 19 and stood up Incident Command before the first case had arrived. I think a number of things. One is we did not have a unified federal approach or unified federal guidance. The second one was, I think, in a then well-intended desire to preserve masks for medical personnel. I think the value of masks was discounted and then somehow became politicized, probably relates to number one that I just mentioned. The third thing is it was just a mad scramble, and it goes back again to federal policy. Everything's been a study of shortages. PPE, testing platforms, testing reagents, case investigators, contact tracers, Nivolumab and Regeneron, ventilators, beds, staff, shortages. And yet we were, because of the lack of a cohesive nationwide strategy, we were competing with FEMA, we were competing with neighboring states, and it drove the price of everything up like crazy, supply and demand. So more than anything, I think we're going to find out that the intersection between public health and public policy is something that we also need to take a strong preparedness approach to, so that we have a strong federal state response, because there were a lot of speed bumps and stub toes over that.
I'd like to just kind of defend the mask issue a little bit that Dr. Norman brought up. You know, initially we said that, and that was said, and certainly our culture here in America is different than some of the Asian countries that have been wearing masks, you know, really since SARS, not only for infection purposes, but for pollution purposes as well. And certainly we understand, and, you know, we were building the airplane while we were flying it. With SARS, you really weren't infectious until 5 to 7 days after your symptoms started. We had no idea that you were so infectious couple 2-3 days before your symptoms start, and people could not even have symptoms and still be infections. So once we got more data, that science changed. But you know, that's an initial talking point for a lot of people. Just kind of want to give some defense to that, actually.
All right. So final question to you directly, Dr. Norman, before we go to our listeners' questions. But the Ebola pandemic. Well, wait a minute. Let's not have that. Any thoughts on what's going on? You were chief medical officer here when we were last concerned, and fortunately, we thought we might have had some Ebola patients at KU, but we did not. What's your sense about the emergence or reemergence of Ebola in Africa again?
Well, it's interesting. I remember Ebola in 1976 when it first emerged, thinking, oh gosh, we don't want that. And then, of course, in 2014, and Dana Hawkinson and you guys and I worked together a lot on this, really 2013 to 2016 in Africa. Different ball game then. Right now, in the countries that are mostly Guinea that is affected, there's immunizations available that were not available in 2014, and there's therapeutics that are available. So I watched the response by the various agencies that come in, and they not only do vaccination of the contacts of an Ebola patient, but the contacts of the contacts and people who might be contacts, and then therapeutics. And so I think the numbers are going to be smaller. I have the same fear, of course, because it's a really bad disease, but I think it's not going to be the same magnitude in terms of the concern for worldwide spread.
All right. Jess, let's see what our questions. I'm sure there are a few out there.
Yes, lots for Dr. Norman coming in just a second, but we promised Brian that we would get to his question today. So I do want to ask this. Brian is a 3-time cancer survivor, a bone marrow transplant recipient. He's on the congestive heart failure program. He's 44, high risk. He's had trouble getting the vaccine and getting on the list. Any recommendations to help him do that? Where should he go?
Yeah, I think my first question is, which state do you live in? Because that impacts the answer. I think to Dr. Norman's earlier thing, if you live in the state of Kansas, you want to go to that website again, Lee Norman.
Yeah, and I'm really sympathetic. Bone marrow transplant, hematologic malignancy patients, and people that are actively being treated for cancer, 18,800 in the state of Kansas, and that's a different population than the 154,000 people that are cancer survivors. And because cancer survivors are, to Dr. Weil's point earlier, evidence shows that are minimally greater risk because of that variable. If I had I would love to have a magic wand with those actively being treated cancer patients, and quite honestly, bone marrow transplant survivors, because bone marrow transplant survivors, and really for that matter, solid organ transplant people on immunosuppressives, are at higher risk, and not only at higher risk for acquiring the disease, but higher risk for having a bad outcome from it. So that is well recognized, and we want to try to advance as quickly as we can to include that group. And it goes back to the earlier conversation, unfortunately, but at least I can assure you that it's well recognized that is a high-risk group within a high-risk group.
So just a comment, some of the transplant patients, transplant data is bone marrow transplant, high risk, kidney transplant, high risk, liver transplant may not be as high a risk. It's interesting to look at some of the differences, and some of the thoughts have been that many of the transplant patients are otherwise healthy. Kidney patients often, by the nature of their disease, are not otherwise healthy. The same thing can be said for being bone marrow transplant patients. So.
Yeah, I think specifically the proportion of the kidney transplant population that has pre-existing hypertension.
Yeah, diabetes.
Right? Elevated ACE receptors in the lungs versus liver transplant, which just happens to be a world that I spend a lot of time in, right? You don't see hypertensive patients.
No.
It's just a different disease. And so that makes sense based on the mechanism of infection.
There's just a different level of illness that goes along with that. Now, if this young man or person lives in Missouri, then I think you just got to go to as many different vaccine sites and try and get registered and make those phone calls as you possibly can. Kansas, you got the websites you can go to, but gosh, I think you just have to Google it and try and find it. A few days ago, there was some extra vaccine in Lynn County, and I know a bunch of people were trying to get through the websites or get to the phone, the public health officer in Lynn County. And I think it's just that, unfortunately, is where we are. But I also think in the next 4 weeks, this is going to change and go upside down, and our challenges will change almost overnight as we get a lot of vaccine. Then it's going to be getting it all administered, because we have a lot of vaccine coming.
Well, and remember, for Brian, I think, right, that's not a very satisfying answer. Keep trying hard, and I understand that. But I would also add, you know how to keep yourself safe, right? We know that vaccine is only one tool in the toolbox, that these other things that we've been talking about for a year now, right? Masking, small bubble size, physical distancing, all of those things that prevent infection still work today. And so you can do that for another couple weeks until this does really turn the tide, till maybe the phasing changes in Kansas, till there's more doses available, whatever the variable is that really
Yeah.
makes it look really different.
It's going to be, and we're going to get there, Jess.
Okay, so Dr. Wild, Lindsay has a question about one of the graphs you showed. She said, so with this graph and the average age at 58 years old, why would the 50 plus population be in the phase 5 with 16 plus?
So I think there are a couple of questions buried in there. Number one, this is an average age. We had a lot of young people who spent 1 or 2 or 3 days in the hospital and didn't really have severe disease. And the phasing, again, was based on severe disease and death. So not many deaths in the less than 50 population. I think Dr. Norman mentioned 85% of the deaths in Kansas were 65 and above. So that's really the reason. The other thing that's buried in here, though, maybe is that the data is very much skewed to the right, meaning skewed to a higher age. If you actually looked at the distribution of ages, you would find that the majority of people were greater than 65 that needed to hit the hospital. There were some, many times with some of the coexisting diseases that we've talked about, who were younger and have pulled that down, but the number of patients, the vast majority, were really in that over 65 group.
Jennifer is asking for some clarification about the rules around vaccinating across state lines and also county to county. It seems the rules are changing and fluid.
Oh boy, Dr. Norman, how fluid are we?
Well, we've been very consistent that said if you work or reside in Kansas, can qualify for a vaccine in Kansas. We are not allocated vaccine for people who live in other states. And it's really, for us, primarily an issue with Missouri. And Missouri has the same rules. Randall Williams, MD, my counterpart there, and I have had frequent conversations about this. We recognize that there are Missouri residents that seek care in Kansas and desire getting their vaccination at their caregiving site. We recognize that there are Kansans that seek care on the Missouri side and desire that. And quite honestly, we don't know where every single dose goes. But as an operating principle, we just don't think it would be fair to Kansans to be vaccinating people from other states, because then it makes it harder for a Kansan to get a vaccine within their home state or the state where they work.
I mean, it is kind of odd because when we say we don't, and yet we do, because if it's live or work, that or work becomes pretty operational in the statement. And it means if you live in Missouri and work in Kansas or vice versa, you can get a vaccine in that state. And I think that sometimes has led to some confusion for folks. I know Wyandotte County has been vaccinating essential workers, and I don't think they really cared where they lived. And to some degree, I don't know that I would want to argue with that, because these are folks who do need to get vaccinated. And so the challenge for us, I think, is the real underlying problem as we get hung up on this is really there's just not enough vaccine. And as we get more vaccine, we will be so much better off. Any other thoughts, Dr. Norman?
No, I want to reassure people that we haven't let vaccines slip through our fingers. We have gotten, the federal government will do what the federal government will do in terms of its allocation formulas, but we have not had any vaccine slip through our fingers. It's all gotten into the state of Kansas. So it's a promise to you that we will do whatever we can to increase the amount of allocation to the state of Kansas, and then to try to do our very best, of course, working with now hundreds of vaccinating sites. I don't know, it might be 700 or 800 vaccinating sites right now. So, but we have not let any slip through our fingers.
Quick question, and you may have already answered this, Dr. Norman, but Gary is asking, Johnson County is reporting they are 21% of the state population, but only receiving 14% of vaccine allocation. Why is that?
Well, I don't have the numbers in the top of my head, but the Johnson County, all counties, well, first off, Johnson County has gotten more vaccine. Johnson and Sedgwick County are kind of neck and neck in terms of they've gotten more vaccine by far than any other counties in the state, which makes sense because they're the two most populous counties. It's been strictly based on a per capita basis. There's a little bit of an adjustment factor for the social vulnerability scale that the CDC has. We have about 15 counties that have higher percentage of people that are at-risk populations, but it's a fairly minor thing. I'll have to circle back, I guess, on this issue, but they have absolutely been given on a per capita basis their fair share.
And Lee, can I just ask a quick follow-up? Are you seeing a different rate of uptake from one county or another, rural versus urban?
Not so much. We'd see it by job sector. For whatever reason, staff in correctional facilities, for example, haven't gotten but above about 50% of the people. Very curiously and unfortunately, nursing facilities staff, as in nursing homes, skilled nursing, are a fairly low uptake. So I don't think we've seen, Steve, much difference from rural to urban, but certain job sectors, yes.
Thing really is perplexing to me because you've seen the impact of it so much.
Yeah, it is interesting. We did, and not a big enough survey to say that this is the sort of national picture or even statewide picture, but some of our geriatrics team has been talking to those staff trying to figure out why. And there is at least a portion of the long-term care facility staff that say, I had it recently. Mm-hmm. So many of my colleagues had it recently that we feel like we don't need to take the vaccine from someone. Yeah. And that question of how much do you need, or is a single dose reasonable after a recent infection? Those things I think are playing into that conversation. And so the only reason I bring it up is I don't think it's quite as negative maybe as we had made it seem early on when we heard 20 or 30% of the long-term care facility employees were accepting the vaccine, because I think that there is some hesitance, of course, in that population, but there's also a piece of it that says we're trying to be good stewards.
Some insight.
How long should people wait?
So, I think that's good insight to understand about that. We were saying that initially with our employees, but as we got more supply, and now the same thing for the nursing facilities and the congregate living facilities. If you're a worker, go ahead and get it. There is no minimum time between infection and getting the vaccine. You do want to wait that 10 days when you're supposed to be isolated and out of the public so that you don't infect other people. But really, after that 10 days of isolation, you can go ahead and start to get your vaccines. So.
And I want to go on the record here and say that 1 year and 1 day in, I might have had rosier colored glasses about something than Steve Stites.
What was that?
This long-term care facility
Oh,
thing.
there you go. Okay, that did take a year and a day. All right, last question.
Last question, and I'm trying to answer several people's question in one. And Dr. Wild, you had mentioned it about kids getting vaccine, but questions about when and if kids like 2 to 10 will get it. Kids 10 to 16, 16 plus. Can you just tell people what they can expect for their kids?
So we got to get a little more data around that, guys.
Yeah. We do. What we heard yesterday was that the studies for 12 to 16-year-olds are ramping up. They're not yet administering, but they are enrolling likely candidates. And so that group will come before the 2 to 12 range. And so we ask about a crystal ball. Did the expert at Children's Mercy have any sense of timing? And that was where the 2022, maybe even 2023, especially for that younger age group, 2 to 12 might come in, which I know is a long time. But there are several steps that have to happen. First, there is the data has to be there, then an EUA for that age group, and then we have to make sure that we have inventory, because that will be in probably the last phase of any plan. And so all of those things have to line up. And I'm hopeful, like any of the other timelines that have been laid out around vaccination, that 2022 is long and that we're much better than that. But at this point, that at least looks like a very reasonable possibility.
Yeah, no, right. We're just waiting for the data.
Hey, tomorrow we will update the COVID-19 impact on sperm and male fertility. Now, we spent some time talking about the implications to young women and to pregnancy. We have not had a chance to really talk about men and male fertility. Dr. A.J. Nangia, Vice Chair of Urology here at KU and a urologist here at the health system whose expertise is in this area, will be joining us to talk about a small study on the topic and compare the impact of sperm by this virus to other viruses. What does it mean? Lee Norman, final thoughts for today.
Yes, I have one final thought, and that is to give a shout out to school nurses throughout the state. School nurses are a different animal, a different kind of person. They're healthcare providers, they are educators, they are counselors, they are enforcers of isolation and quarantine. They run interface between parents and the education system. So they wear many, many hats, and I think oftentimes go unrecognized. And so today, for me anyway, and from my agency, a big shout out to school nurses, and just keep on trucking. You guys have really been the glue that has held so many things together. So thank you.
Guys, Dave?
Yeah, I think my final thought today is a little bit different than normal. It's sort of a thank you, not just to school nurses, but of course to that group, but to really everyone, to our teams. We talked yesterday about the impact to us, but we didn't talk about the impact of the last year to our teams. To all those in the community, whether it's our public health officers, the teams at KDHE, our epidemiologists, our school nurses, you name it, right? It's just countless groups who have really committed so much over the last year. The numbers that we shared today talk about our perspective, but leave out so many. And so I do think it's important to say thanks really to everyone who's made an impact, even if that means practicing the pillars of infection prevention and wearing your mask.
Yeah. We're always concerned about the variants that we know about. And the variants that we don't know about. We know the vaccines, there's a lot of question, will they help, will they work? There's a new article in the New England Journal of Medicine today looking at, laboratory research and showing that the vaccines that we have, particularly the Pfizer vaccine is what they looked at, does continue to give you protection against certain variants, and those would be the UK variant, the South African variant. So that's all very positive. So moving forward, hopefully we will continue to gain protection from those. But also we have the ability to, the vaccine makers have that ability to pivot and change the vaccines as we need to as well. So I think moving forward, that's all good news.
It is good news. And I just want to say a couple things. So first of all, for my singing about Texas, my mother was born and raised in Texas, and I spent a good part of my life growing up in Texas. It's interesting because the state of Texas lifted the mask mandate, as did Mississippi, but Houston, San Antonio, and Dallas did not lift their mask mandate. And why is that? Because we know that this simple little mask keeps you safe. No matter where you go, no matter what you do, this mask will take care of you. Hey, that was a little rhyme, not bad. Because you see this little bugger right there? We want to beam that little bugger up and out of the country. That was my Star Trek reference for the day. Please make note. You got to beam this thing out of the planet. And the only way to do that is to make sure you practice those rules of infection control, that you do get vaccinated, and we do take care of each other. We'll be back tomorrow. And in the meantime, even as the CDC has just reaffirmed, there's still no place like home.